Dr. Leena. Dr. Leena Priyamda, I think she has joined all the way from other corner of the world. And I know Leena for long. I was a senior resident when she was doing her MD at PGI Chandigarh. So Dr. Leena is presently a consultant pediatric endocrinologist at Rainbow Children's Hospital, Hyderabad. She is closely working with SPAD right now, and she's at helm of affairs, I would say. She did her pediatric endocrine training at Sydney, Cincinnati Children's Hospital and SGPGI Lucknow, PDCC. So I welcome Dr. Leena for this session, and she would be talking on hypoglycemia and exercise in children with type 1 diabetes. Dr. Leena, please. I think you can share your screen now.
Yes.
So you are in Sydney right now, Dr. Leena, is it?
No, actually, I'm back. I finished my fellowship. I am back and I have joined Rainbow Children's Hospital, Hyderabad, Banjara Hills. So
you can make it slideshow. Yeah.
Yes. And thank you, Dr. Rakesh. Yes, we know each other for a long time, and glad to be knowing you. And thank you, Monica, and the entire team for this wonderful session. I'm sure it is very useful for the audience and for the practicing pediatricians and the endocrinologists who are having who are viewing this. Thank you, Monica, for this wonderful session. I would be talking on hypoglycemia and type 1 diabetes, and subsequently exercise and type 1 diabetes. And I think it is a very interesting combination of topics because it is so intertwined, I would say. Okay. So what is low blood sugar and why are we bothered about it? It is the commonest acute complication of type 1 diabetes. It is a major barrier to optimal care. We want to have a good A1C, we want to decrease the A1Cs and the blood sugars, but usually the families and even the doctors are so scared that child will land in a hypoglycemia that sometimes the optimal care is actually not done. There is significant anxiety in the part of the family and the child, and younger children, as we are dealing with children, are more at risk. So since the normal blood glucose regulation, as the blood glucose reaches the lower boundary of physiological euglycemia, there is inhibition of endogenous insulin. As there is inhibition of endogenous insulin, then subsequently the counter-regulatory hormones start appearing. The initial symptoms are behavioral changes, irritability, agitation. There is the child suddenly become very quiet. There may be tantrums. There may be unexplained anger, and all those things. Then as blood sugar starts reaching 70 and below, the counter-regulatory hormones like the glucagon, the adrenaline, the growth hormone are released. And because of this adrenergic symptoms, the symptoms of shakiness, palpitation, sweatiness, all these things happen. As blood sugar further lowers towards the 50s, the neurophysiological dysfunction happens. There is poor concentration, blurred vision, blurred speech, giddiness, loss of consciousness, and this is and the child may go into coma and seizures. Subsequently, so other non-specific symptoms are nausea, headache, tiredness, and hunger. How much is too low? So 70 milligram per deciliter is a clinical alert. That is, it is a threshold value for initiating treatment in diabetes, because we know that once the physiology or the pathology has started and the blood sugars have reached 70, they are further likely to go down, and it is best to intervene at that point of time. Less than 54 milligrams per deciliter is called a serious hypoglycemia, because that is the phase when there is defective hormonal counter-regulation, the neurogenic symptoms and the cognitive dysfunction occur. At this point of time, it is important to know about hypoglycemic unawareness or impaired awareness of hypoglycemia, or IAH. With the recurrent episodes of mild hypoglycemia, there is a defective counter-regulatory hormone response to subsequent hypos. There's a 2 to 3-fold reduction in the epinephrine responses. This causes impaired adrenergic warning symptoms during hypoglycemia, and all these shakiness, tremors, all these symptoms are not there, and the ability to detect the onset of hypoglycemia is diminished. 2 to 4 hours later, when this hypoglycemia management hasn't happened, then the sugars going to 50s and lower, and neurological signs like seizures and coma can happen. There is no great way to manage this hypoglycemic unawareness, but it may be reversed by avoiding hypoglycemia for 2 to 3 weeks. So generally, it may be a good idea to reduce the insulin doses so that the hypoglycemia is completely avoided for 2 to 3 weeks. It has also been mentioned that bursts of high-intensity exercise may restore counter-regulatory responses. What are the risk factors for hypoglycemia? We know that blood sugar is in a tightrope balance with food, which increases the blood sugar, and the insulin and exercise, which decreases the blood sugar. Hence, if there are missed meals, the low-carb food, or the losses like diarrhea and vomiting, then you can expect low sugars. So for example, missed meals, child has taken tiffins to school and has not eaten, or the tiffin has fallen down, he is not able to eat, and you may expect that there will be a lower at that time. Low carb food, for example, if a child for breakfast has 2 toasts and eggs, or 2 chapatis and eggs, and on one particular day doesn't have the chapatis but has 2 eggs, thinking that might be enough. So eggs don't have carbohydrates, and only if he takes the same dose of insulin for those 2 eggs, what he takes for the chapatis, he may have a low carb food, a relatively low carb food for the amount of insulin that he is taking, and will end up in hypoglycemia. We can always obviously understand the diarrhea and vomiting. Of course, sick day Sirisha will be taking over, where it is not so simple. Insulin and exercise. So insulin will lower sugars, whatever the level of sugar is. Hence, insulin, if it is excessive, either by mistake, or it is factitious, or by purpose, or is relatively increased because of the in relation to the carbs being taken, it is ill-timed, or sometimes there is a mistake in the type of insulin that is given, then that can decrease blood sugars. The physical activity will also decrease blood sugars. Then malabsorption, particularly celiac disease, hypothyroidism, hypocortisolism, Addison's, the liver problems, renal problems should also be ruled out if they are unexplained hypoglycemias. What are the risk factors for severe hypoglycemia? So what is severe hypoglycemia? And even with hypoglycemia-induced cognitive dysfunction like coma and convulsions is known as severe hypoglycemia in children. So younger children less than 6 years are more predisposed. If a child has lower A1C levels, then they are more predisposed, either because he is having persistent or significant hypoglycemia, that the A1Cs are lower, or the child is or the family is targeting a significant tight control that the A1Cs are lower. Hypoglycemic unawareness also leads to severe hypoglycemia, and previous severe hypoglycemia also predisposes to further severe hypoglycemias. So what is the management? It is the rule of 15. So 15 grams of fast-acting carbohydrates. Once there are symptoms of low blood sugars, then we check our blood sugar. If it is less than 70, 15 grams of fast-acting carbs have to be taken. These are some examples of fast-acting carbs. So glucose-D or sugar are the commonest ones. So 15 grams means 1 tablespoon or 3 teaspoons of sugar. Then we have, or the glucose-D, there'll be around half a carton of apple juice or mango juice. The glucovita balls are pure sugars. They also can be used and they're handy to keep. Then in Amazon, there is a stock of glucose gels, which are useful if a child is unconscious or his child has a cognitive dysfunction to treat hypoglycemia. Once this has been taken, 15 minutes later, sugars have to be rechecked. They should be more than 70, preferably more than 100. If they're more than 100, then the acute care has been managed. If it is still less than 70, then we need to repeat the rule of 15 till the child is better. Further management. So if the child is unconscious, then at home immediately glucose gels may be tried. If there is a facility for IV, then IV 2 to 5 ml per kg of 10% dextrose can be given. Or supposing IV is also a problem, then feeding tubes with 25% dextrose may be tried. Vomiting is common when there is hypoglycemia. It can cause recurrence of hypoglycemia. Additional complex carbohydrates, once the 15 grams of sugars has been given and sugars have become better, complex carbohydrates, a small snack like one chapati or one bread, one slice of bread, or a small meal can be given. And the amount of carbohydrates required will depend upon how big the child is, what is the insulin currently going on, and what caused the hypoglycemia. Food containing fat delays absorption of blood sugars. Hence, things like ice creams and Amul chocolates, dairy milk are not a good agent to improve hypoglycemia. Everyone must be aware of glucagon. Glucagon is very useful for severe hypoglycemia, and all families with type 1 diabetes must be asked to keep it at home. So whenever there is any severe hypoglycemia, any cognitive dysfunction, altered sensorium, then intramuscular or subcutaneous glucagon can be given 1 milligram in more than 25 kilo child and 1.5 milligram in less than 25 kilo child. This is a glucagon hypokit where there is a vial and a syringe in which it can be loaded. This may not be available in all places. Sometimes these vials and ampules are available, which also can be used. There is a concept of mini dose glucagon. That glucagon 1 milligram is taken in a 100-unit insulin syringe, and 2 units is given for a 2-year-old child, and more than 2 years old child, 1 unit is added for every year. This small dose of glucagon raises the blood sugar by 60 to 90 milligrams per deciliter, and it is very effective in impending hypoglycemias and preventing severe hypoglycemias. So now that we know that hypoglycemia is so common, what are the symptoms and what causes it? Prevention of hypoglycemia is the most useful thing. So diabetes education. The role of diabetes education cannot be overemphasized. The families and children must know what causes hypoglycemia, how to prevent it, how to alter insulin doses. There must be strict instructions about carrying a hypo kit, which involves the glucose monitoring device to diagnose hypoglycemia, and hypo foods at all points of time. Parents and teachers and friends and close associates have to be trained to recognize hypoglycemia in a child with diabetes. Identification bracelets and alerts are extremely useful. Modifying blood glucose goals is also important. A child who is going to recurrent hypoglycemias, the blood glucose goals, targets, and the A1C targets have to be modified. They can be a little higher, and the A1C goals can be a little higher. Use of technology in terms of the Flash Libre or the continuous glucose monitors, insulin pumps, small dose unit, 0.5 unit pens are quite helpful. In unexplained hypoglycemias, identifying celiac disease, Addison's disease, hypothyroidism is also very important. And in the last but not least, identify psychological issues and factitious hypoglycemias. Is the child or the individual trying to create hypoglycemias purposefully? Sometimes some children go into hypos because they want those hypo foods, the sugars and the chocolate and the toffees and the candies, because they know they will get it when the child is having a hypoglycemia. In summary, after treating, investigate for insulin overdose, either by mistake or purposefully, missed meals or low-carb meals, any illness, specifically diarrhea and vomiting. Look at the role of exercise. Was there an unaccustomed exercise? This I'll be coming to in the many later slides. Use of alcohol in older children. Systemic diseases. Lipohypertrophy is another interesting thing which has to be very carefully evaluated. Supposing child has a lipohypertrophy and insulin is being given, because at sites of lipohypertrophy, there's erratic insulin absorption, and so a higher dose of insulin is taken when for having the sugar control. Once we change that to a normal site where insulin absorption is all right, then the insulin is too much for the carb intake, and there may be hypoglycemia. Other drugs like OHAs can also combine with insulin and cause hypoglycemias. If there is a chronic hypoglycemia, that is, if body is used to having higher sugars most of the time, if the sugar falls, even if it is not in the hypoglycemia range, The body feels a relative hypoglycemia and can cause symptoms, though it will not be a true hypoglycemia. There is significant risk of mortality. There is something called a dead in bed syndrome, where there's a combination of severe nocturnal hypoglycemia with autonomic neuropathy, and which leads to abnormal cardiac activity. And children and individuals can be found dead in the morning because of all this. This is a very serious issue, and any severe hypoglycemia at night specifically needs to be looked into very carefully. So after hypoglycemia, so let us move on to exercise, physical activity, and type 1 diabetes. So exercise, we all know, is very important, and all academic bodies, they advocate exercise at least 60 minutes a day. We will discuss regarding benefits, barriers, and how to optimize glycemic control. So benefits of physical activity is all known. In type 1 diabetes, this is probably all the more important because physical activity improves the insulin sensitivity. That is, for the same 1 unit of insulin, the blood glucose response would be better. So in the whole, you will need less insulin for the same amount of improvement in blood sugars. The cardiovascular risk and the lipid profile is lowered. HbA1cs are better, and all activities, physical activities, they usually cause psychological well-being. The barriers of exercise, the fear of hypoglycemia. Children and individuals with type 1 diabetes always fear that the exercise will cause hypoglycemia. So sometimes they take a lot more food when exercise is involved, or they avoid exercise, and that is a significant problem. And compounded by general habit of sedentary lifestyle. So we don't have time, and there's a lot of studies to be done, a lot of tuitions to go to, and generalized lethargy. So what do we mean by physical activity? Any physical activity is called physical activity, whether it is free play outdoors, whether it is a dance session, whether it is a Zumba, whether you're walking your dog, whether it is strength training, team sports, combat sports, running, cycling, swimming, tennis, football, badminton. So in other words, any physical activity, and any kind of physical activity with a child enjoys should be encouraged. The key word in this is move. The child must move. So recommendation is at least 60 minutes of physical activity daily, moderate to vigorous at least 3 times, muscles 3 times a week, muscle strengthening 3 times a week, and bone strengthening 3 times a week. And it is not surprising to know that in today's world, a lot of type 1 diabetes children are overweight, contrary to what we think. A type 1 diabetes as a thin, lean child, and a type 2 diabetes as an overweight child. It is a type 1 diabetes child who are really getting overweight, especially when we are matching insulin to food. The chances of it becoming overweight is quite important. So normally we think that all exercise causes hypoglycemia. There are some activities like anaerobic activities, which include strength training and sprints, which actually increase the blood sugars instead of causing a hypoglycemia. Strong aerobic activities like cycling, swimming, running, they cause hypoglycemia. Usually our sports will be a combination of anaerobic and aerobic activity. So it is quite possible that the blood sugar changes may be unpredictable. And this has to be kept in mind when we are planning the activity and the insulin doses. Also, the exercise, we need to know whether it is routine exercise. If it's a routine exercise in day-to-day life, then the insulin and food is usually accounted for. If it is unaccustomed, we need to take care about the food and the insulin dosing. Same as for scheduled and unscheduled. How heavy the exercise is going to be and what it is regarding time of day. Is it going to be before a meal? Is it going to be at the peak activity of peak action of insulin, peak insulin action profile? So all these things will have an impact on whether it's going to be a hypoglycemia. So check blood sugars before, during, if it's a significantly prolonged exercise, and after exercise. Do not exercise if blood glucose is more than 300 milligrams per deciliter and ketones are present. If blood glucose are more than 250 but no ketones are present, then ideally we should give a small bolus of insulin, wait for the sugars to come down before exercising. ISPAD is coming up with great detailed outlines on this insulin dosing. Prolonged exercise can cause prolonged hypoglycemia. So example, if there has been a football match for 3 to 4 hours in the afternoons, then we can expect that because of glycogenesis, glucose is used up throughout the night and child can go into hypoglycemia midnight or early morning, and hence it would be better to decrease the night long-acting insulin that night and think about the early morning, the next day's breakfast in pre-meal boluses. Severe hypoglycemia in the previous 24 hours is a contraindication to exercise. Food adjustments, carb intake before moderate physical activity. So that is always advisable. In our setup, a medium-sized banana is a good carb intake before activity. Carb, protein, fat meals 3 to 4 hours prior if it is going to be significant sports. Additional low-carb snacks at bedtime is usually advisable, and it is always advisable to be ready with hypo snacks and hypo foods when the activity is going on. Insulin dose adjustments, as we said, insulin dose adjustments will depend upon the timing and the type of activity. If we are expecting that the activity will be around the peak action of insulin or around this time when the insulin is acting, then it will be good to decrease the pre-meal if it is a scheduled exercise, pre-meal boluses, or maybe taken or additionally take an extra carb. And as we said, in a prolonged activity, there may be hypoglycemias later on. So that night, it will be useful to decrease the night long acting so that hypoglycemia doesn't happen. Technology, as always, technology always comes to help if it can be used properly. So continuous glucose monitoring is very useful to see impending hypoglycemias. Insulin pumps are quite useful because the basal rates can be altered and the boluses can be very minimal boluses can be given for the meals. And newer insulins, which are more rapid acting insulins, can also help because they will change the insulin action profile. And role of diabetes education cannot be overemphasized. With this, I stop my slide share and happy to take any questions.
Yeah, thank you, Dr. Leena. So I don't think there are any questions in the chat.
We have a
yeah,
question.
Dr. Monica.
How many experience on using nasal glucagon for hypoglycemia?
No, I do not have any experience. I'm not sure if anyone has it here.
Okay.
I mean, I don't know, Dr. Rakesh.
No, I don't think it's available yet in India.
In India. So, sir, in like US, I mean, if anyone is using nasal glucagon.
Okay. So there are situations, Dr. Leena, where there could be hyperglycemia after exercise.
Yes.
So what could be those situations? And
so as we expect, as I told in my slide, anaerobic activity like your sprints, then weightliftings, all those things can cause hyperglycemia. And a common, so in those cases, probably the child will need insulin bolus. It is advisable to give half a bolus, half a correction dose instead of a full correction dose. The second thing is it will be usually be overzealous correction of hypoglycemias or overzealous carb loading, which thinking of an impending hypoglycemia with exercise.
okay, so general rule again for I think for exercise again it should be normal glucose before we start exercising.
Yes.
So higher the glucose, the sugar may rather go high, and lower the glucose, obviously the sugars may go low. So that's important.
In fact, probably where blood ketometers are very commonly used. So once the sugars are high, they would be checking the ketones and then decide regarding exercise. In our setup, I don't think it is very practically possible. So, and I am not actually really sure how many people check their sugars before exercise. And these are which we need to do, but I'm not sure if everyone does it.
Yeah, obviously, if exercise is not in routine, then they should be checking. But yeah, if it is in routine, then it may not be required. Yeah. Okay, so I hand over to Dr. Monica for the next session.